Concept of PG capsule is basically to discuss with young minds if they have come across any rare case and how to deal with that, what went wrong. So here, no faculty lecture, nothing. It's all you only present. We are here just to discuss upon that. And rest assured, the best presenter in each session, they will be rewarded. Okay. So now I'll welcome Dr. Ritika Sachdeva, ma'am. Ma'am is the director of Center for Sight, New Delhi, and I think entire division. And Dr. Hemlata, you know her quite well. Midterm she did excellent live surgery demonstration. So we will starting the session, and I hope we get the agenda soon. Good morning, ma'am. So all our chairpersons are ready now. So now I would like to invite our first speaker, Dr. Sokanti Srinath. Yeah, please.
Can I start? A very good morning to all the esteemed faculty here. I thank the AIOS for giving me this wonderful opportunity to present a case in the first day of the conference in the first session as the first speaker. Moving on to my case, I would like to present an interesting case where we can see how a single organism can present in multiple ways. Herpes simplex virus keratitis has varied presentations in the cornea. It can affect the epithelium, stroma, and endothelium as well. It is mistaken for other pathologies and hence proper treatment is usually delayed. It is the most common infectious cause of corneal blindness in developing countries. Moving on to the case, a 52-year-old woman presented with chief complaints of redness and pain in both the eyes for the past 1 week. She gave history of fall of dust in both the eyes 10 days ago. It was removed by native methods where the dust was removed with another person's tongue. Following this, redness, pain, decreased vision, and photophobia developed in both the eyes. There's no history of contact lens usage or no history of bathing in rivers, ponds with contaminated water. On examination of the right eye, the vision was 6/18, IOP was 12 millimeters of mercury, cornea showed 3 mm stromal edema below the pupil, KPs on the endothelium, Hudson-Starley line, and the corneal sensation was decreased as well. Anterior chamber showed flare 2+ and cells 2+, lens showed nucleus sclerosis cataract of grade 2, fundus was normal. On examination of the left eye, vision was 6/60, IOP was 11 millimeters of mercury, and the cornea showed 10 mm dendritic corneal ulcer with terminal end bulbs staining positively with fluorescein, subepithelial haze, DM folds, Hudson-Starley line, and the sensation was decreased as well. Lens showed nucleus sclerosis cataract of grade 2, and the fundus was normal. We did syringing for both the eyes and the ducts were free. The RBS was 82 milligrams per deciliter. Following this, a clinical diagnosis of right eye disciform endothelial keratitis and left eye dendritic epithelial keratitis was made, both probably due to herpes simplex virus. We gave, for the right eye, prednisolone acetate 1% 3 hourly eye drops, Jan cyclovir ointment 0.15% 5 times a day, and cyclopentolate eye drops BD. For the left eye, we gave Jan cyclovir ointment 0.15% 5 times a day, Moxie eye drops hourly, and cyclopentolate eye drops BD. We also gave oral NSAIDs and lubricants for both the eyes, and the patient was asked to follow up in 3 days. After 3 days, the visual acuity in right eye improved to 612 and left eye to 636. We can see that the stromal edema in the right eye is reduced and the ulcer was healing in the left eye. Patient was advised to taper the steroids in right eye and continue the same treatment in the left eye. Moving on to the literature review, as I told earlier, the HSV virus can affect the epithelium, stroma, and endothelium as well. In epithelium, it presents in the dendritic or geographic ulcers. In stroma, as in non-necrotizing or necrotizing ulcers. And in endothelium, disciform keratitis, trabeculitis, and iridocyclitis as well. The herpetic eye disease study is a multi-center prospective clinical trial. It gave various results. Out of the main are the fact that topical steroids yield faster resolution of stromal keratitis and oral acyclovir may be beneficial in HSV iridocyclitis. The patient followed up 2 weeks later. Vision improved from 618 to 69 in the right eye, and in the left eye from 660 to 624. Stromal edema cleared completely in the right eye, and ulcer was healing well in the left eye. Clinical implications of this case is that herpes virus can have varied presentations in the cornea. It can cause vision impairment, recurrent flare-ups, and potential complications like corneal scarring. Hence, it is important that we diagnose these cases early, and antiviral treatment are crucial for managing symptoms and preventing long-term issues. Thank you.
Thank you, Sukanti. So after 3 or 4 case presentations about keratitis, then we'll take up questions, okay?
Yes.
So now you can go back and sit there. So once the keratitis cases are over, then we'll ask you questions. So next speaker is Dr. Amit Kumar. Dr. Amit is here? Okay. Dr. Priyanka Ramanathan. Dr. Pankhudi Burma. Anyone from this session? Shivangi? Abu Amir, Prince Abu Amir? Yeah, please. So in the meantime, Prince is ready with his PPT. This is question to the panelists, do we do syringing probing routinely in all cases of keratitis nowadays?
Routinely we are not doing. Only in case of suspicion of bacterial ulcers we do syringing.
I think it's the same practice that we all routinely do a RO plus. If there is mucoid discharge, a history of recurrent conjunctivitis, or if it's a bacterial ulcer where you're suspecting a predisposition, due to that we do syringing.
We do routine RO plus on the patients.
Prince, you can start.
Good morning, everyone. I am Dr. Prince from UCMS Delhi, and I am here to present a very interesting case studying the effect of topical insulin on a non-healing corneal ulcer. So what happened was a 51-year-old South Asian farmer presented to the OPD with the chief complaint of redness and mild pain in the left eye since 1 month. There is history of exposure of left eye to the farming urea 1 day before the symptoms started. So the patient did not have much symptoms. That's why he was very much comfortable for the past 1 month, and he was putting eye drop moxifloxacin 2 hourly, which he took from local medical store. There is history of similar symptoms in the left eye 5 years ago following trauma by rice bran, which rendered residual diminution of vision. There is history of left facial palsy since childhood after an ear infection, and there is no history of systemic illness. Right eye ocular examination was within normal limits. Left eye ocular examination, the vision was finger countings at 3 meters and no improvement on pinhole was seen. Facial asymmetry was asymmetrical because of facial palsy. Extraocular movements were foreign free. There was mebomitis, there was lag of thalamus, but the Bell's phenomenon was good. This is the corneal examination. We can see diffuse and circumciliary congestion. We can see 5 into 4 mm epithelial defect, fluorescein stain positive, and we can see the punctailed epithelial erosions. We can see infiltration. We can see feathery margins, satellite lesions can be seen. We can see hypopyon, that is 1 mm hypopyon, that it was immobile. And we can see a corneal facet, which was probably due to the previous illness. There is congestion, and in anterior chamber, 4+ cells were present. Pupillary reaction was sluggish but normal, and lens vitreous and fundus, because of the hazy media, they were grossly reported to be normal. IOP was within normal limits. So what we did was investigations. Routine general investigations were all within normal limits, such as hemogram, LFT, KFT, blood sugar, viral markers, syphilis, chest X-ray, ultrasound whole abdomen. They were all within normal limits. What is important was that the posterior segment was not involved, despite having 4 plus cells in the AC. That is, ultrasound B scan showed only vitreous degeneration with posterior vitreous detachment. On microscopy, Gram stain was negative, but the KOH stain was fungal hyphae was seen on KOH stain. Despite of that, bacterial and fungal culture showed no growth. That was probably because due to lab error or clinical error. We started the patient on broad spectrum antifungal and antibiotic topicals, cycloplegics along with lubricants. We started oral doxycycline for blepharitis. But despite this treatment, for 1 month, there was no decrease in the size of the epithelial defect, although there was significant improvement in the infiltration and hypopyon. For the epithelial defect, we did temporary lateral tarsorrhaphy, but the patient was very much uncomfortable and it was non-compliant, so we released it after 5 days. Then we started topical insulin, 25 international units per ml, 6 times per day, along with tapered previous medications. 40 international units per ml, this concentration is available in our setup. So how did we make 25 international units per ml? We took 6.25 ml of this insulin and diluted it with 3.75 ml of distilled water to get 10 ml of 25 international units per ml. Now we can see the progress. Within 3 days, there was significant reduction in the infiltration and significant reduction in the epithelial defect, which moved to reduce more after 1 week of the starting insulin. As you can see in this image, there is a significant improvement. It was given for 2 weeks, and within 2 weeks, the epithelial defect was completely healed, although the punctate epithelial erosions were still present. You can see the healing of the corneal ulcer. The anterior chamber reaction is cleared. There's superficial and deep vascularization. Surrounding corneal haze is reduced, and the ulcer has moved on to become nebulomacular corneal opacity. Insulin was stopped after 1 week of this. So in total, 3 weeks of topical insulin was given. For 2 weeks, we gave it for 6 times per day, and then it was tapered for 1 week. This is the clinical picture after 2 weeks of stopping insulin. On follow-up, the vision was 6/60. Lag of thalamus is still present with good Bell's phenomenon. So we gave the patient topical lubricants, and all the examination like lens, vitreous, and fundus were within normal limits. So now the patient is planned for optical penetrating keratoplasty. In literature review, most of the studies done using insulin and corneal ulcer were done for neurotrophic ulcers only. In Tong C. Maya et al. In 2020 Canada used 25 international units of this for neurotrophic ulcer, and they noticed re-epithelialization of the cornea within 1 week. Similar results were given by Wong et al., Yavis et al., and other studies, but their concentration varied. They used 1 ml, 1 ml, and 50 international units per ml. There is one thing that in diabetic corneal ulcers, diabetic neurotrophic corneal ulcers, the higher insulin dose should be used as stated by Mr. Bession and Ling in 2013. Now, what is the mechanism behind this? We don't know for sure, but the presence of insulin receptors on the cornea and the lacrimal gland and increased prevalence of keratopathy in diabetic patients suggested that insulin may contribute to corneal wound healing. A rabbit model showed that topical insulin might alter the ocular surface response by increasing tensile strength in corneal wounds, and an in vitro model of immortalized corneal epithelial cells showed increased cell migration and better addition of epithelial cells to extracellular matrix. And no adverse effects were noted, no systemic adverse effects were noted with the use of topical insulin at concentrations up to 100 international units per ml in any of the published cases. You can see all these references as I have given here. So in conclusion, topical insulin may be a simple and effective treatment for non-healing corneal ulcer. Insulin-like growth factor along with substance P has been shown to be an important modulator of corneal wound healing. Treating predisposing infections like blepharitis is very important, and exposure of the cornea should be managed properly, because as long as the cornea is exposed, we won't be able to heal the epithelial defect. Thank you so much.
I think that was a very interesting case. We usually first use things like autologous serum, amniotic membrane, but sometimes the penetration of the drug through the amniotic membrane goes down. So using a topical therapy like insulin, I don't think many of us have tried that. But what was the reason that you chose to taper insulin? Is insulin to be tapered? You said you tapered the therapy.
Yes, ma'am. In the study done in 2020 Canada, we took it as the primary study, and they gave it for 3 weeks, and then they tapered it for 1 to 2 weeks, depending on the response. So our epithelial defect healed within 2 weeks, and then we tapered it.
Okay, so as per the literature that you studied,
yes,
the optimum duration is about 2 to 3 weeks to give insulin?
Yes, ma'am, 2 to 3 weeks. But there are no specific systemic side effects, so it was not actually mentioned the maximum duration of insulin that can be given. So in 2 weeks, our epithelial defect healed. So then that's why we tapered after that.
Right. So insulin anyway has a anti-inflammatory as well as an epithelial regeneration role. So
Yes,
it is
ma'am.
an interesting use of insulin.
Yes.
So congratulations on your work.
Thank you,
Any
ma'am.
comments from the panelists?
AV team?
Do you routinely give, or is it the first case?
No, ma'am. This was the first case, but after seeing this result, we have done this in 3 or 4 more patients, and we are starting to make a case series about that also. We have 5 patients who have been improved by topical insulin, so we'll be publishing that, I think.
So the 5 cases, the 5 cases, they were all infective keratitis, or have you tried in other indications like neurotrophic ulcers or post-graft?
Ma'am,
What
there
were
was
they-
this viral keratitis also, that also healed. But 2 of them were fungal, and 1 patient also had systemic diabetes, and 1 was purely viral, so it has shown promising results.
When you prepare the insulin, how long can you use the prepared insulin?
Ma'am, there is no literature that I found that,
that's
but
why,
we
because
personally,
I think a lot of the people will be encouraged to use insulin.
yes, ma'am,
so
but
for everybody.
we refrigerated. First of all, we make it under very aseptic conditions, then we refrigerate it, and maximum we use 1 vial for 3 to 4 days.
Okay.
Yes, ma'am.
Nice presentation, Prince.
Thank you, sir.
But for since most of us are resident here, could you just tell us how to manage such cases? Post-infectious keratitis, infection part is almost healed, but epithelial defect is not healing. Okay, so what are the other approaches that somebody can do? Because for preparing insulin drop, you need aseptic setup,
Yes, sir.
which is there like centers like UCMS, maybe RP center. But for a practitioner, what are the approaches they have?
Sir, if there is no infective component and if there is only persistent epithelial defect, then we can use, first of all, we have to give a vigorous amount of lubrication for the patient, and we can put BCL, we can put amniotic membrane graft, we can use tarsorrhaphy also. But BCL is, the easiest and most promising in that case. But when we gave insulin to our patient, there was still a bit of infective component present, so we gave insulin along with broad-spectrum antifungals and antivirals.
Yes, because one of the limitation of autologous serum insulin eye drops, since these are growth factors,
Yes.
there is a fear that it may incite more infection.
Yes.
Okay, that's the concern that we have. Anyone from the house want to add any question to Prince or the first presenter? Okay, what is the experience of AMG to the panelist? There are several articles which say that AMG can be done in such cases. So I would like to ask Dr. Astha, Dr. Heblata, and Dr. Ritika, have they tried AMG in post-infectious non-healing epithelial defect, and what's their experience on this?
I usually do tarsorrhaphy. So most of my patients heal with tarsorrhaphy. So very few cases I have done amniotic membrane graft, and both of them work well. Both the tarsorrhaphy and the amniotic membrane graft. So I mostly prefer tarsorrhaphy for my patients.
I think AMG is also a great tool in neurotrophic ulcers. The infective element having gone, AMG is actually a barrier to the penetration of certain drugs. So AMG is a great tool. We've tried using, in deeper ulcers, even multi-layered. But we normally stitch in the AMG with sutures. You can try glue also, but you need the normal AMG. The ones that they are recommending as the pre-prepared frozen, they hardly have any utilization in our experience. So we are doing the traditional AMG, not the ones that are, pre-prepared frozen. I forgot the name of the commercial. What is the name?
Yes, so in infective keratitis, the AMG is, it is a matter of debate and controversy because there's a lot of inflammation. So the AMG tends to break down and disintegrate because of the inflammation in these conditions, and there's also a chance of it being a biological membrane getting infected. So however, but we saw that it can be useful. It is not absolutely contraindicated in infective keratitis, and in very difficult and recalcitrant cases, it can be tried as a temporary
Thank
bandage.
you. So the basic.
I think for the benefit of the PGs, another newer modality that is still not fully proven, experimental like insulin, is collagen cross-linking. So you should know about that also in the treatment of refractory corneal ulcers.
So basically tarsorrhaphy, that is available to all of you. You can try that. or BCL, right? If that doesn't work, then you can go for all this innovative therapies like autologous serum, insulin eye drop, you know. But surprisingly, this drops works well. Whatever the experience that we have with autologous serum or cord blood serum, they usually works well because they contain a lot of growth factor. So thank you, Prince. Now coming back to the first presentation, I think these are the two presentations in our keratitis series. Any questions for the first speaker from the chair? Dr. Sokanti, right? Dr. Sokanti, it was a bilateral keratitis, right? So, and you're treated with, you can come here, you know. So you treated it with topical acyclovir.
We treated the patient with Jancyclovir, sir.
Jancyclovir. But
The-
my
the
point is,
stromal-
suppose if somebody is having a bilateral herpetic keratitis, why not to go for oral acyclovir?
Sir, first we want to try topical first and see the response and then go for oral. For the right eye, since the stromal involvement was there, we gave topical steroids, sir, as well as the acyclovir also.
So there are 2 points of not debate but discussion here that I would like to put to the chairs. Whether in the bilateral herpetic keratitis, whether one should go for oral acyclovir and not put the patient into the pain of putting 5 times the same ointment twice in the eyes, or they would still prefer topical. Ritika ma'am?
Even topical works well in epithelial lesions.
Yes, ma'am.
Oral can be indicated if there's high level of epithelial toxicity from the topical medication. In bilateral cases, we do give oral depending on the overall profile of the patient.
Okay.
We are open to giving oral also.
Yes.
Another question I had is, did you give steroids at the same time you gave the topical therapy, or did you wait for the epithelial lesions to subside before starting the steroids?
Ma'am, only for the right eye we gave topical steroids, ma'am, because the right eye had only stromal involvement. The epithelium was intact. For the left eye, we didn't use any steroids, ma'am. Left eye had epithelial keratitis, dendritic ulcer, ma'am.
Okay, and what was the IOP?
IOP was 11 in the right eye, 12 in the left eye, ma'am. It was normal.
Okay, especially when there is keratouveitis and a manifestation of keratouveitis is intraocular pressure increase because trabeculitis,
Yes, ma'am.
then I tilt more towards giving oral antivirals also.
Yes, ma'am.
Did you evaluate for the systemic factors because bilateral viral keratitis is very rare?
Yes, ma'am.
So did you evaluate for the systemic conditions like HIV or any autoimmune diseases?
Ma'am, this patient
on
first ever,
medication.
she gave history of no previous episodes, ma'am. So this was the first ever presentation, ma'am. So we didn't do any other evaluation. Since if she presents another time, we thought of evaluating further for the systemic illness, ma'am.
But bilateral, it's always
Yes.
better to evaluate
Yes,
systemic
ma'am.
factors.
Yes, ma'am.
So the point to be taken is, whenever you are dealing with a bilateral keratitis, please do a complete systematic evaluation.
Yes,
Okay, that may be some immunocompromised case, specifically, you know, with herpes. And second point, this is a concept that if you use topical, then it has less systemic toxicity compared to oral acyclovir. But if you go to Western countries like USA, where topical acyclovir has not been approved yet, in those countries they prefer oral therapy for even epithelial keratitis. So if it's a bilateral keratitis, you have the choice of both topical as well as oral. Oral, the only point is one drug will work for both the eyes. That is the only advantage of having that.
Yes.
Corneal sensation, had you mentioned that?
I didn't mention corneal sensations also.
Ma'am, it was mentioned in the slide, ma'am. Both eyes, the corneal sensation was decreased, ma'am.
And one point of discussion could be as ma'am asked, now, when it is a epithelial plus stromal keratitis, what should be the approach?
Sir, stromal keratitis is usually due to the immune reaction, sir. So it won't subside with antivirals. But since epithelial involvement is there, we can't give steroids as it may increase the keratitis. So it's better to start with antivirals itself. Once the epithelium heals, we can start on steroids.
Yes, that's true. So any difference in approach by the chairs? Whether you'll wait till the epithelium heals, then start steroid, or after 48 hours of antiviral therapy, you'll start steroid?
We will wait until the epithelium heals completely. Then we will start the topical steroids.
I think same for us as well. And for keratouveitis, please remember the cycloplegics and the anti-glaucomas also to be added,
Yes.
right? In addition to the steroids.
So that is what probably most of us do, because if you give steroid in presence of epithelial keratitis, it may become a geographic ulcer. So that thing you have to keep in your mind. And as ma'am said, most of the time this keratouveitis is associated increase in IOP, but since the patient is having corneal ulcer, we tend to forget. Either we check it digitally and we don't do any NCT or anything like that. So in that case, you tend to miss the IOP part. Especially when you will notice patient will say कि sir deep seated pain हो रहा है, आँख के अंदर pain हो रहा है, no? So in those cases, you have to give cycloplegic and anti-glaucoma medication. Thank you, Shokanti. That was a wonderful presentation.
Thank you.
And I don't think anyone is there in this keratitis session. Dr. Amit, Priyanka, Shivangi. Shivangi is there. Yeah, Shivangi, please come. So Priyanka Ramanathan. Okay, Priyanka. So you'll be presenting atypical corneal ulcer. Wow, great. That would complete our spectrum.
A very good morning to one and all. I'm Dr. Priyanka. I'll be presenting a case on atypical corneal ulcer. Atypical corneal ulcer refers to the certain corneal infection caused by microorganisms that are not commonly encountered in clinical practice. It is often associated with worse visual prognosis and significant ocular morbidity if not identified and treated early. If any risk factors that is pertaining to specific atypical infection, it should raise a high suspicion of the specific atypical keratitis. As atypical infections are notoriously difficult to grow on cultures, so a diagnostic strategy will be helpful in identification of the rare causes of microbial keratitis, and it is highly warranted. So most common causes of atypical microbial keratitis can be classified into bacterial, like Mycobacteria, Nocardia, Burkholderia, and Achromobacter. Parasites such as Acanthamoeba and Pythium insidosum. Fungal like Microsporidia. So coming to our case, my patient was a 65-year-old woman who was former by occupation. She came with a complaint of ocular trauma to the left eye with a tree branch while working in the field 2 weeks back. Following which she developed pain, redness and watering and associated diminution of vision, which was worsening over the days. She also gave a history of intolerance to light and associated with some discharge. Patient consulted to outside hospital immediately after the trauma. She was told that she had an eye infection for which topical medications was started. 3 days later, she underwent an eye injection and subsequently referred to our hospital. She did not have any other negative findings and no systemic comorbidities. Her general examination and gross ocular examination are within normal limits. Her vision in the right eye was 6/9, which was explained by cataract, and other anterior-segment examination had no significant findings. Left eye vision was hand movements close to face and PR being accurate. Eyelashes showed matting and with the presence of lid edema, but lid closure was adequate. In this picture, we can see circumcorneal congestion, and in the cornea, there is presence of pinhead-shaped infiltrates surrounding the corneal ulcer of size 6 into 6.5 millimeter with surrounding stromal infiltrates. Also, there was endothelial plaques, and anterior to that, there was stromal infiltrates. Satellite lesions were seen adjacent to the corneal ulcer, and there was obvious AC exudates and hypopion, which was partially mobile and was measured to be 4.2 millimeter in height. Corneal sensation could not be elicited as patient was having photophobia. Other anterior segment examination in the left eye could not be elicited as patient had corneal ulcer. IOP was digitally normal. So my clinical diagnosis would be left eye corneal ulcer. I would keep my first differential diagnosis as bacterial keratitis since it's most common, followed by fungal keratitis, and then atypical and polymicrobial keratitis. We did our first corneal scraping, and it was showing no organisms in Gram-Stain or KOH. We empirically started the patient on antifungals like natamycin and amphotericin B and antibacterials such as vancomycin and tobramycin, along with cycloplegics. Since patient did not show any improvement and ulcer was also progressive, so we took the patient for intrastromal intracameral antifungal injection after the anterior chamber wash of exudates. Intraoperatively, after the anterior chamber wash of exudates, we could clearly see the V-shaped pattern that was emerging very much clearly. Ulcer was scraped and the exudates and the scraping was sent for microbiology. We also gave intracameral injection of moxifloxacin. Based on this typical pattern, nocardia was suspected and medications were modified into amikacin, linezolid and moxifloxacin. Patient symptomatically improved and culture also showed chalky white colonies on blood agar, which confirmed the nocardia keratitis. Ulcer size was gradually reducing and hypopyon was disappearing. We could see that with appropriate treatment, the cornea is becoming more clearer and hypopyon is disappearing. The V-shaped pattern was clearly noted here. So antibiotics were slowly tapered to QID dosage and stopped. Nocardia is a rare and frequently misdiagnosed cause of corneal infection. Nocardia is found to be prevalent in soil of South Asia. It has associated risk factors like prior ocular trauma with soil or dirt and prior ocular surgery such as refractive surgery, topical steroid use and contact lens wearer. The diagnosis of nocardic keratitis is often missed or delayed due to the lack of familiarity and an unusual pattern that mimics more common causative organisms. So the management of nocardic keratitis has a variable response to most first-line medications used for bacterial keratitis. Though topical amikacin is the first-line agent, in some cases like refractive corneal ulcer, second-line treatment like topical tobramycin, imipenem and linezolid can also be potential options. So the empiric therapy should not be delayed if there is a high suspicion of nocardic keratitis. The topical therapy should be continued until a complete resolution of the infection. The prognosis depends on the corneal nocardic keratitis. They heal very rapidly, resulting in scarring and vascularization. But delay in management can lead to nocardia scleritis. Rarely they can progress into complications like endophthalmitis or corneal infection, leading to permanent blindness. On follow-up, 1.5 months later, ulcer healed completely with the corneal scar. So antibiotics are tapered and stopped. Now patient is registered for optical PK and she will be called for after 3 months of drug-free period. Here the learning points from our case will be that knowing the typical finding of nocardic keratitis, so its timely detection and its management brings us a favorable clinical outcome. Thank you.
So is it a routine practice to wait 3 months after cessation of the treatment?
We should be sure that the nocardic keratitis has resolved. So the corneal scarring might be there, but after that we should wait for at least 6 weeks to 3 months to be called for PK.
So did you do OCT to decide whether to do lamellar keratoplasty or optical keratoplasty?
She's still under the topical medication, is still not stopped fully. So after that we'll plan for corneal transplantation.
So, as residents, are you routinely doing corneal scraping? Because sometimes if you've not done it properly, then maybe you don't get in the microbiological examination. So, are you routinely doing for all cases, and what all culture plates do you plate for a case of keratitis?
The first scraping was found to be negative only. Second scraping and X-ray showed the nocardic keratitis. It might be that the specimen was not adequate enough to show to show in the gram stain or KOH. And for this case, routinely we do blood agar and seborrheic dextrose agar. In this case, in blood agar, it shows chalky white colonies.
Okay. Thank you, Priyanka. That was a wonderful presentation, but one thing I am disappointed with you is you didn't cite my article. We have a review article on atypical keratitis. So in current eye research, it's a review article, you all can follow that. So apart from that, that was a nice presentation. Only few things. See, when would you suspect an atypical keratitis? That is important for all of us to know.
When first thing, the most common will be bacterial or fungal. So if the patient is compliant enough, but still the ulcer is progressing, we could think about atypical keratitis. And second is that most of the atypical keratitis can mimic fungal also. So they will have more the signs other than symptoms. So even if the patient is compliant with the empirical antibiotics, still the ulcer is progressive, we can think about atypical keratitis.
So I won't say it's progression. Any keratitis where you are giving full treatment and the ulcer is neither progressing nor healing, and it's already 1 month or 2 months, it's saying like that only. In those cases, you should suspect atypical keratitis, because most of the atypical organism, they don't progress that rapidly, and they are sensitive to routine antibiotic, but not fully 100%. So there will be some response, but again that may flare up or it may remain static like that only. And then you should suspect atypical keratitis. And nocardia, would you give steroid in nocardia keratitis?
No, we don't give steroids. Only if it's only stromal involvement, then it will be more of an immune reaction rather than the organism actually. So actually in this case, it was ulcer more than the stromal reaction, so steroids are avoided.
And what about that amikacin? Initially you started with 2.5.
Yes, sir.
Okay, then you made it 1.25.
Yes, sir.
Any rationale for that?
First we start with the high dose so that the ulcer progressive will be reduced. Then we can slowly taper.
So any opinion from the experts whether to reduce the dose completely, like reduce the strength, sorry, or reduce the frequency? What should be the right approach while tapering topical antibiotic, fortified antibiotics? Dr. Jaya, one of our panelists is sitting there, so I would like to ask her. So whether she will prefer just taper 2.5% gradually and stop, or reduce the strength to 1.25 and then continue for a long time. Yes, because you know, the MIC, you are giving 2.5, right? So the moment you make it 1.25, there are some organism dormant, they may flare up. Okay, so because remember, when you are giving antibiotic, your bacteria or fungus, they are also starting their protective mechanism. Okay, so now the organism also well prepared to tackle 2.5. So if you make it 1.25, then there will be problem. Okay, so don't reduce the strength to which the organism is responding. Better to taper it off gradually. Any other comment from panelists? Anything from the house? From all the PGs? This is the MCQ for you all, okay, that typical appearance. Can you tell us what is the origin of this, how this term is coined? Which are the other synonyms? Chalo, this is a quiz question. We'll be doing in 16th March, Ajanta Pharma Science and Fun quiz. All of you are welcome. A question will be there on this, okay?
It mimics ring infiltrates.
No. Anyway, thank you. Okay.
Thank you, sir.
So I think we are done with our keratitis part. Anyone from Preeti, Shivangi, Pankhudi, Amit? You are? Preeti. Okay, Preeti, you can have your PPT. Preeti Khan. Amit is not here, right? Shivangi? Okay, so this is our last on keratitis session. So Preeti, your PPT is ready? Yeah. So she'll be speaking on multidisciplinary approach in a case of exposure keratitis with vestibular schwannoma and 7th cannular palsy. Oh.
A very good morning to everyone. I'm going to present on multidisciplinary approach in a case of exposure keratitis with vestibular schwannoma and 7th cranial nerve palsy. In my case, a 54-year female presented to us with chief complaint of diminution of vision and inability to close her right eye for past 2 years, chronic foreign body sensation, photophobia in right eye for past 2 years, right-sided facial weakness for past 2 years, right-sided hearing loss for past 2 years, gait unsteadiness, headache, and drooling of saliva from right side of mouth since 6 months. The history of present illness is the same as of chief complaint, and history of past illness was not significant. The positive on ocular examination, the positive finding in right eye was Best corrected visual acuity was hand movement close to face, perception of light was present, and projection of ray was accurate. Patient can't read any plates of Ishihara chart. There was reduced wrinkling of forehead, corneal sensation was reduced in right eye, and there was inability to close upper eyelid of right eye. On slit lamp examination, mild conjunctival injection, especially in inferior palpable fissure, was noted, and on corneal examination, 4 into 3 mm inferior epithelial defect with central areas of around 20% stromal thinning with horizontal linear superior border was noted. Talking about the degree of legophthalmos, 6 mm of legophthalmos on gentle closure of lids and 5 mm legophthalmos on forceful closure was present. Tear breakup time was reduced to 6 seconds. Corneal epithelial defect was noted. Oval-shaped corneal ulcer with heaped up margin was there. Blink rate was infrequent and incomplete. Ocular motility was normal, but strength of orbicularis oculi muscle was decreased in right eye. There was 12 mm of wetting while doing a Schimmer's test. On systemic examination, facial examination, fifth cranial nerve, all the sensation was reduced in the distribution of fifth cranial nerve, and right eye corneal reflex was absent. On examination of seventh cranial nerve, minimal deviation of angle of mouth to left, reduced wrinkling of forehead in right side. On eighth cranial nerve examination, Rennie's negative and Weber's lateralized to left side. Routine investigations were within normal limit. We did special investigation CT brain and MRI brain. On doing CT scan shows lobulated mass compressing fourth ventricle, and MRI showed extra-axial enhancing space-occupying lesion at right cerebropontine angle with perifocal edema and mass effect leading to compression of brainstem, cerebellum, and fourth ventricle. Management was basically done by neurosurgery and ENT specialists, in which they did right retromastoid suboccipital craniotomy, and subtotal excision was done under GA. Histopathological report confirms diagnosis of vestibular schwannoma, in which Antony A and Antony B cell was present. In this case, the patient was unable to close the upper eyelid of right eye for prolonged period of time, leading to exposure keratitis, and for this later tarsography was done. In discussion, vestibular schwannoma is a benign intracranial tumor arising from vestibulocochlear nerve with a varying natural history. In our case, the schwannoma, due to its close proximity to seventh cranial nerve, seventh nerve root compression occurred, and the patient developed lower motor neuron type of facial nerve palsy preoperatively with legophthalmos, which further complicated by development of exposure keratitis over time. Though this patient was operated for the schwannoma, facial nerve palsy persisted, and beside medical management, lateral tarsography was performed to protect the cornea from exposure. Thank you.
Thank you, Priti. I think that was a nice case presentation. So the point to be taken is you have to look for all possible cause of neurotrophic keratitis when you are dealing with such cases. We already have discussed this the exposure keratitis, neurotrophic keratitis in one of the presentation. Any extra thing to add from the panelist? No one.
I think that all of us should note that lubricants we often give, it is very important, but you must use preservative-free lubricants in all these cases because you give it over a long term. And what antibiotic would you like to give prophylactically? If you
Ma'am, fluoroquinolones group should be avoided.
Yes.
And so we can use other groups.
What are the other? What is your preferred prophylactic antibiotic for
Like
just exposure
cephalosporins.
keratitis?
No. And anyone? You people also should participate, or I'll randomly pick somebody. Dekho. Prince, what is your take? You presented that insulin, no? So which antibiotic should be preferred in neurotrophic or exposure keratitis, where you are not suspecting any infection, but you just want to give some prophylactic antibiotic which is epithelial friendly? Any brand drop that is available in market? Have you heard of mycin? Mycin contains chloramphenicol and polymyxin B.
Chloramphenicol.
So remember, whenever you want some antibiotic which is epithelium friendly, you can prescribe that drop. Well, I don't have any interest in that company, but that came to my mind. Okay, so you can use that. Chloramphenicol, tetracycline eye drops, these are quite epithelium friendly.
We don't use it routinely because they may not be as bactericidal, but here you're looking at a prevention of infection without compromising the epithelial baseline levels, right? So mycin is routinely given for prophylaxis.
You are right. Don't give fluoroquinolones because specifically gatifloxacin. And in experimental studies, it's well proven gatifloxacin retards or suppresses your epithelial regeneration. So it's better to avoid fluoroquinolone drops in exposure or neurotrophic keratitis. Thank you, Priti. That was a nice presentation.
Just one question from me, Praful. When would you like to open up the tarsography? Maybe from the panelist only we can know the opinion.
Ma'am, when we will plan for PKP and all, then we can open this tarsography.
See, exposure keratitis is there, right?
Yes.
So PKP comes later on, once we are sure no exposure, no surface issues. But exposure keratitis, you have done tarsography, now the epithelium has healed. So would you take it out immediately or you'll wait for some other thing to improve?
So we will wait for some duration, and if it get progressed, if we are planning for amniotic membrane grafting and all, then we can open.
Okay, let me give you another clue. Suppose lag ophthalmos is persisting.
Yes, sir.
Okay, there is no improvement in your 7th cranial nerve palsy. So would you still remove the tarsography or you will continue, okay, let it be like that?
No, so we will continue with the tarsography.
Dr. Jaya,
Yeah,
what's your advice to them?
No, that's right. Even I would not like to open the tarsography. And oculoplasty people I've seen, they do some other lid surgeries to improve the closure.
And a gold weight to reduce the symptoms of leg ophthalmos, we can use gold plate, platinum chains, and hyaluronic acid mask.
You
We
can
can
do
use.
palpebral sling or botulinum toxin injection also. You can consider. So until the sensations come back, you cannot open the tarsography. So because if you do any planning for any other surgery, if the sensations are absent, again the ulcer is going to come back. So you have to check the sensations before opening the tarsography.
Thank you. So we'll move on to our next group of presentation, and I see Dr. Navya is here, right? Yeah, Navya, please start. So she will be presenting an interesting case of brittle cornea syndrome with blue sclera case. Blue sclera, okay. Ishita, if you are there, okay, you can come here once our presentation is over, right?
I'll start.
Yeah, please.
Yeah, good morning everyone. Myself, Dr. Navya from Bangalore Medical College and Research Institute. So I'll be presenting a case of brittle cornea syndrome with a blue sclera. So this patient, 53-year-old male patient, he presented, who's a daily wage laborer from Bangalore. He presented with a complaint of trauma to the left eye 4 hours ago, and following which he had diminution of vision. So he gave an history of trauma to left eye with a cardboard box at his workplace around 6 p.m. and he presented to the ER at around 10 p.m. on the same day with a diminution of vision associated with pain and bleeding. There was no history of any ocular trauma or ocular surgeries previously and no systemic comorbidities. Family history, no history of similar complaints in the family members, no history of any consanguineous marriages in the family. His personal history and in general physical examination, the patient had hard of hearing and there was hyperflexibility of the small joints noted. In systemic examination, everything was normal. So summarizing it, it was a 53-year-old male patient with hearing impairment, hyperflexibility of small joints, who came with a complaint of diminution of vision following a trivial trauma. So coming to the ocular examination, the facial symmetry, head posture was normal. Coming to the vision, right eye had a distant vision of 624 parts, improving to 618, and best corrected visual acuity was given -6 spherical and -1 cylindrical, which came up to 612. Left eye was PL negative eye, and there was mechanical ptosis and lid edema of the left eye. Right eye was normal. Then on examination of the sclera, there was bluish discoloration of the sclera noted in both the eyes. Coming to the corneal examination in the right eye, the size, shape, and the surface was smooth and the transparency was fine, but there was thinning of cornea noted throughout the thickness. And corneal sensation were intact. In the left eye, there was a full thickness corneal tear from 3 to 10 o'clock hours with expulsive choroidal hemorrhage. Then coming to the anterior chamber, anterior chamber was normal in the right eye, but a flat AC in the left eye. Iris of left eye showed the iris prolapse between 3 to 10 o'clock hours. And lens in the right eye had nuclear sclerosis grade 1 with cortical cataract. And posterior segment examination was normal in the right eye. And this was the photograph of the left eye on presentation. There was a corneal tear with expulsive choroidal hemorrhage. And the right eye showed bluish discoloration of the sclera and the thinning of the cornea throughout. The hyperflexible joints were seen in the thumb, and there was a contracture of the small joints of the little finger. And investigations, routine blood investigations were done, which were all normal. And right eye specular microscopy, central corneal thickness, pentacam, and anterior segment OCT was also done. In right eye anterior segment OCT, it was seen that the thickness was 247 micrometer. And the pentacam of the right eye showed global thinning with a thickness of just 210 micrometer. And the corneal thickness spatial profile showing a flat line, and you can see the total corneal thickness, total corneal thinning. And this is the left eye B scan showing the diffuse dense hemorrhages. So the diagnosis was done as right eye senile mature cataract with nuclear sclerosis grade 1 with cortical cataract with a brittle cornea. And the left eye was a full thickness corneal tear with iris prolapse with expulsive choroidal hemorrhage secondary to the penetrating trauma with a dense vitreous hemorrhage with a brittle cornea. Left eye primary corneal tear repair was done, and post-op moxifloxacin with dexamethasone, carboxymethyl cellulose, and HPMC was given. And oral steroids were started, vitamin C to cover for the dense hemorrhages, and protective glasses was told. Like right eye, optical penetrating keratoplasty was planned, but the patient was not willing for the surgery, so we couldn't do it. This is the post-operative images of the left eye. There's a lot of cheese wiring seen on the inferior surface of the cornea, the suturing as well. And to evaluate for the blue sclera, the family member, the son of the patient was also screened, pentacams were done. So we could see there was thinning, like it was 458 micrometer of thickness was noted, both in right eye and the left eye, but he's kept under observation for now and no intervention as of now. Thank you.
Thank you. Do we have Ishita Maurya here? Yeah, please. So both the cases are similar. So after her presentation, we'll discuss this.
Good morning, respected judges and colleagues. Today the topic of my presentation is brittle cornea syndrome, which is one of the rarest cases, and only 60 cases have been documented till now. So what is brittle cornea syndrome? Brittle cornea syndrome is a rare autosomal recessive connective disorder with ocular and auditory manifestation. The hallmark of this particular syndrome is the propensity to cause the corneal rupture after the innocuous trauma. The reason being the thin central cornea, almost less than 400 micrometer. The other ocular features that are present are keratoconus, keratoglobus, refractive high myopia, and retinal detachment abnormalities. BCS is of two types that occurs due to mutation in the transcription regulator protein, the first one being the zinc finger protein 469, and a type 2 that is PR domain containing protein 5. Moving on to our case, a 9-year-old female presented to our outdoor with the complaints of the gradual dimness of vision in both eyes with the history of frequent change of spectacles. Her family history was negative for any known genetic ocular and systemic disorder. As the pedigree chart shows, the inheritance was autosomal recessive type. Her uncorrected visual acuity was FC 1 feet and FC 2 feet, and her best corrected visual acuity was 6/60 in both eyes. The slit lamp examination shows the presence of blue sclera, horizontal scamus, thinning of cornea with both eye central corneal opacity. The features of keratoconus like Munson sign, prominent corneal nerve endings, flishering, and the Vox striae was present. Musculoskeletal finds examination shows long and slender extremities, hallux valgus, loose skin, hyperextensibility of small joints. Moderate to severe sensorial deafness and umbilical hernia was noted. on systemic examination. The first most important investigation that was performed was corneal tomography, and it shows that the cornea was thinnest at the center, with being 384 micrometer in right eye and 373 micrometer in the left eye. The Kmax in the both eyes were more than 50 diopter, suspecting it to be the prone to develop the corneal ectasia. The other investigation that were done were tympanometry, proton audiometry, ultrasound, X-ray imaging. And the most important the investigation that was done to finally make the diagnosis was whole genome sequencing, which confirmed that there was mutation in PRD-M5 gene at the variant C1768, where the cytosine is replaced by thymidine, thus confirming our diagnosis to be brittle cornea syndrome type 2. The Sanger sequencing was performed on the patient and her family members. It shows that as a normal sequencing here, it shows that the cytosine is replaced by the thymidine in the patient. The brother and sister have the normal cytosine basis, and the mother and the father both have the cytosine and the thymidine basis overlapping. The intervention that we preferred in this case was medical management. The patient was asked to avoid the contact sports and fleeing. She was asked for protective polycarbonate glasses. At present, the patient has not developed the corneal rupture. She's kept on the follow-up every 3 months, and her best corrected visual acuity is 6/60. There are many studies that are done on the particular disease, particular syndrome. The most important being by the ophthalmologist Burkett Wright, and studies have revealed that BCS type 2 has more prone to develop the hearing defects and the musculoskeletal findings, and there are lesser chances of corneal perforation in BCS type 2 as compared to BCS type 1. We had kept the patient on the close follow-up with the serial corneal scanning and the other musculoskeletal findings. The clinical implication of this case being that this particular mutation, that is 1768 cytosine replaced by thymidine, PARG termination, is the first mutation to be reported and documented till now. Timely diagnosis and treatment is must, as if it is not timely diagnosed, it may develop the corneal rupture. Though the therapeutic methods like the contact lenses, keratoplasty, and collagen cross-linking are recommended, but the efficacy is unsatisfactory and limited. So we preferred for palliative and the conservative management. And since the particular disease shares common features like blue sclera and musculoskeletal findings with kyphoscoliosis, EDS, Ehlers-Danlos syndrome, osteogenesis imperfecta, and Marfan syndrome, so we need to timely diagnose and treat the patient before a corneal rupture occurs. Thank you.
Thank you, Ishita. The one point that I liked about your PPT is we prefer palliative treatment. So remember this point. In brittle cornea syndrome, any surgical intervention, usually you will be disappointed after that because you cannot suture, the cornea keeps on tearing during surgery. So palliative conservative should be the way to go for, unless there are some acute complication like corneal rupture. So Dr. Ritika, you had first speaker.
Yeah, no, the first speaker I think had highlighted that there was a the other eye was 6/6, myopia, of course, 6/6 with glasses. 6/12 is good vision. You just give these patients polycarbonate glasses, tell them to have lifestyle modifications which does not predispose them to much trauma, and that is the therapy that you give. For advanced cases, rather than do penetrating keratoplasty, of course if it's not ruptured, and epikeratoplasty has been documented by some, and earlier cross-thinking could not be done because these corneas were thinner and they did not fall as part of the Dresden protocol. But now with adaptive fluence, that basically means you're using lesser energy, people have started cross-thinking these corneas also. So these are therapies which are easier to do. Whenever you try and suture these corneas, they tear up, the graft rotates, and once you have an open globe in a penetrating keratoplasty and you're not able to manage to do a good graft, you are in a soup. So therefore, closed globe procedures and palliative procedures are best for these, right? Even if the cornea is 200 microns, then you do an epikeratoplasty over that, rather than open the globe, and even 200 microns in today's adaptive fluence, you can go up to 200 microns to cross-link. Of course, adaptive fluence is a concept that has just come out, and people have not cross-linked 200 yet, but that may be a future frontier.
And how much of the
I'm sorry, I can't hear you. If you're talking about suturing, sometimes you have to take larger bites. You sometimes have to use 11-0 nylon and even almost go up to the sclera, and sometimes these grafts get converted to sclerokeratoplasties if you're not able to suture the cornea itself.
Ma'am, if you have to try C3 for these patients, since it's already 200, like if we take out 40 to 50 microns of epithelium, is that still okay?
Yeah, so the
Just
concept of adaptive fluence is that you're using lesser energy. See, earlier you were doing accelerated cross-thinking where you were using the same energy.
lesser duration.
Power and time were, as per the Bunsen-Roscoe law of reciprocity, if you were increasing power, you were decreasing time. But you were using the same amount of energy. Now what happens when the cornea itself has lesser collagen is that you need lesser energy because there's less collagen to cross-think and you don't want the endothelial toxicity to come in. Therefore, instead of the 5.4 energy that was traditionally used, you reduce the total amount of energy. Okay? And then you can, sporal has gone as low as 250. Okay? So, but of course, the collagen response of a keratoconus patient and a brittle cornea patient will be different. So, there is still not enough evidence to really tell us how well collagen cross-linking works. But now, this may be tested more with the adaptive fluence. But the bottom line is, don't try and open a globe till you're sure you'll be able to handle it, right?
Any questions from the house? Any comment from the panelist? So these are rare cases. You have to be extremely cautious about these cases. And first case, it's quite late. Usually, these patients, they present in the first 10 year or 20 year with perforation. The patient is lucky.
It's just an incident.
Yeah, but both of you presented quite well and documentation was perfect. Thank you for that. So anyone from this session, Ahan Shah, Ruchi Agarwal? Ahan, yeah, please come. इसमें डिस्प्ले कर रहे हैं वो, अब इसके बाद देगा वो टेबल.
पहले वाले लोग भी आ गए.
Hello. Hearty good morning to one and all. I'm Dr. Ahan from Jipmar, and today I'll be presenting a case on keratoconus. So an 11-year-old school-going male child was brought to the OPD by his mother with complaints of frequent and vigorous rubbing of the eye for the past 2 years. Apart from this, the child also had irritation and watering from both the eyes, complaints of difficulty in seeing the blackboard, and there's history of chronic eye rubbing, also history of skin allergies and recurrent cold, which are aggravated in winter season. There's no history of any spectacle usage or contact lens usage for this patient, no history of discharge, photophobia or pain, no history of long-term usage of topical medications, no history of previous consultation for eye-related problems. He doesn't have any relative in adolescent age group with history of frequently changing glasses. There is no history of any medical illness or abnormal joint mobility. The child is conscious, cooperative, and cooperative to time, place, and person. He is well built and adequately nourished for age. There is no evidence. Rest of the systemic examination was within normal limits. Ocular examination showing head posture erect, eyeball position orthotropic, uncorrected visual acuity being 612, not improving further. On retinoscopy using cyclopentolate drug with working distance of 0.66 meters, the best corrected visual acuity was at minus 3.25 diopters of sphere and minus 5 diopters of cylinder at 10 degrees, 6.6 and N6. Retinoscopy by direct distant ophthalmoscopy showing scissoring reflex and Charlot's soil droplet reflex. Eyelids, there is no sign of Munson sign is negative, eyelashes normal, some papillae were present. Coming to the examination of cornea, the cornea was clear, there was no evidence of any thinning or flacious ring. Now in this figure you can see that there is inferior thinning. I'm sorry, the mouse is not working, but in the lower image you can see that there is inferior thinning and over which there is an area of steepening. Also on making and slit you can see that there is a whitish line which disappears on pressing the globe. There is no evidence of any prominent corneal nerves, no evidence of protrusion of the cornea. Anterior chamber depth, Rizzuto's sign was positive, pupillary reaction was within normal limits, IOP was 14 millimeters of mercury. And this is the left eye examination showing similar findings. Corneal thinning noted inferiorly below the apex with few parallel stress lines present in the deep stroma that disappear on pressing the globe, suggestive of Ward's try. So this is the diffuse slit lamp examination showing Rizzuto's sign and the Munson sign being negative for this patient. Fundus examination was within normal limits. So to summarize, an 11-year-old male presents with complaints of excessive eye rubbing and difficulty in vision since 6 months. On examination, signs like Ward's try, Rizzuto's sign, scissoring reflex, oil droplet reflex were seen, with rest of the examination being within normal limits. My provisional diagnosis for this patient based on the signs and the age is both eye keratoconus. I like to proceed with anterior segment optical coherence tomography, corneal topography. And this is an AIOC showing that there is no evidence of any focal thinning and no evidence of any epithelial abnormality. The pentacam scan showing asymmetric bow tie with inferior steepening, but there is no skewing. There is flattening in the anterior and posterior floats with more in the posterior float, suggestive of initiation of keratoconus changes. Package showing more than 100 microns of difference between the central and peripheral corneal thickness. And Balin's Ambrosio enhanced ectasia is showing that the enhanced best fit sphere is showing pathological changes favoring the predisposition of keratoconus, and also the corneal thickness spatial profile is reaching 2 standard deviations, suggesting the same. This is the same for the left eye with asymmetric bow tie, inferior steepening, and no skewing for the radial axis, and posterior float is showing more flattened areas with significant thickness changes. Again, the same finding here. So the stage will be Amsar chromic stage 2, ABCD stage 2 with no evidence of scarring, and these are the KISA percentage for the right and left eye, showing increased severity in the right eye. So since the patient was from far, we decided to go on with C3R based approach because the follow-up was in question. So based on dressing protocol, the patient was approached with C3R.
You can skip this, you are running short of time.
Yes,
skip
sir.
the procedure of CXL. Yes.
Yes. And then post-operatively, this demarcation line is seen, suggestive of increased corneal strengthening. Thank you.
So thank you, Ahan. Most of us knows about keratoconus, but for PGs, this could be a long case in your exam. So all the signs as Ahan highlighted that you should remember. And CXL, yes, just for the discussion purpose, what are the indication of CXL? Because you highlighted one important aspect. If you are sure that the patient is not going to come back for follow-up, it's better to go for CXL. So which are the indications of CXL in keratoconus?
Sir, as apart from this point, if there is documented progression in terms of topography, that the ectasia is increasing, the thinning is progressing, then we should go for C3R. And it should also be done with usually more than 400 microns of residual bed thickness. If it's less than that, then we should be cautious in the use of C3R.
So what's the take of the panelist on this point? When would you prefer to go for CXL without even documenting progression?
The patient is young age and who is in the age of progression, like below 15 years, they are more prone for progression. So those patients, even when we don't see the progression, even on the topography, we go for CXL.
Yes, ma'am.
Tushar?
Somebody in teens, especially early teens, you would go ahead with cross-linking without looking for progression. But somebody in their 20s especially, even in early 20s, you should look for progression, do serial topographies, and then consider
this was an 11-year-old male child with reduced age, severity can be high with the lack of compliance for follow-up. So,
and in kids, also look for VKC. Yeah, that's also an important factor.
Correct. So you mentioned that there were giant papillae here. So when you're talking about management, you should also talk about treating the VKC. Because that is also important for you to prevent the progression of keratoconus.
Yes, yes.
And
correct,
even
sir.
in the history, it would have been nice if you asked for a history of eye rubbing, because all of these are quite relevant to the condition that you diagnosed.
Understood, sir. Thanks.
So VKC treatment is important from two standpoints. One is itself, the eye rubbing causes progression. Secondly, if you go in with a bad surface, post-cross thinking, you are likely to have sterile infiltrates. And you want a good response to the cross thinking, right?
Yes,
For the epithelial off treatment and the epithelial on, I think largely the debate is moving in favor of remove the epithelium and use other modalities to circumvent the.
So the point for all of you is, if you are suspecting the patient is going to progress, Tushar highlighted, right? Patient below 19 years and having risk factor like VKC with eye rubbing, then in those cases, it's better not to wait for documenting progression and go ahead with CXL. For those cases, you can directly go with CXL even with one visit. And second, as ma'am highlighted, if the patient is having VKC, the ocular surface is altered. So sterile infiltrate, and there is a high risk of moxifloxacin resistant keratitis in post-CXL patients. Okay, so there are two wonderful series, one from Narayan Netralaya, one from RP Center. You can go through that. So control VKC before going for CXL. Thank you, Han.
Thank you so much, sir.
So anyone from the next group, Asmita? Yeah, Asmita, please come. Sanjay, you are there? Sanjay Sharma? Mrunal? नहीं वो नेक्स्ट में है. अस्मिता कम. काला प्रिया? Not there. हाँ. अश्विन कुमार? अनिक घोष? ठीक है, अनिक is there. Kopal Srivastav? ठीक है, अनिक is there. So we are on time.
Good morning, everyone. My case presentation today is on interface keratitis and lamellar keratoplasty. Keratoplasty, as we know, is corneal grafting. It is of various types. In DALK, the majority of the corneal tissue is removed, leaving behind the decimate endothelial complex before suturing the donor corneal graft, which is devoid of the decimate membrane. DALK improves the clinical outcomes with fewer complications due to endothelial rejection. Interface keratitis, generally between the host and the graft tissue, can be a devastating and sight-threatening complication, as we will see here. A 17-year-old boy with diagnosed keratoconus more in the left eye than in the right eye. Vision in the right eye was 6/24, best corrected to 6/9. Left eye was 4/60 without any further improvement. There was corneal scarring in the left eye apically, most probably due to healed eye drops. Thinnest pachymetry was 438 and 321 respectively in the right and the left eye. Was planned for right eye C3R and left eye DALK. The donor tissue was 65 years, in situ cornea excision. Size of donor taken was 9 mm, stored previously in cortisol, and death to transplantation time was 5 days. Technique used was Anwar's big bubble technique. On POT1, mild pain, conjunctival discharge, and ciliary congestion was there. On examination, there was yellowish white deposits at the graft-host interface as confirmed by AIOC2024. Urgent therapeutic PK on the same day was planned with an oversized graft of 9.5 mm. The removed lamellar graft, host DM, unused corneoscleral rim, and storage media were sent for microbiological examination. On POD2, infiltrate and hypopia reappeared and progressed rapidly, and the patient was started on topical Vanco and Septa along with atropine, eye drops, and oral corticosteroids. Pre-op routine blood test and corneal topography was done to confirm keratoconus. Post-op gram staining of the corneal button confirmed gram-negative bacilli. Culture and sensitivity came back positive for Klebsiella species after 2 days, sensitive only to colistin, and colistin eye drops were started hourly. The second TPK was done within 1 month with optical grade cornea. Graft uptake in this case was good without any recurrence. In review of literature, 2 cases of AIIK following DALK with multi-drug resistant Klebsiella are presented. First, following DALK in a 42-year-old woman due to granular dystrophy. The second case of co-infection by Klebsiella and E. coli, AIIK, reported by Boschak et al. In Kolkata itself in a 20-year-old male with vasculite healed viral keratitis. In follow-up, the patient has completed 4 months follow-up presently with no recurrence and attained a best corrected vision of 6/9 in the left eye. In clinical implications, interface keratitis is common mostly with fungi like Candida. Multi-drug resistant Klebsiella infection in interface keratitis is rare. Only 4 cases have been documented in literature so far, out of which 2 cases have been discussed here. All cases reported have had very acute onset within 1 or 2 days. In conclusion, early diagnosis, urgent therapeutic PK, and investigations to detect causative organism and initiation of specific drug therapy for the organism is mandated. Thank you.
Thank you, Asmita. Any comments from the panelists?
So I've had a Candida post-endothelial keratoplasty. Most of the time the infection comes from the donor, and sometimes we like to warm the tissue for endothelial keratoplasty, and that was supposed to be responsible. But once you have such an infection, particularly after endothelial keratoplasty, the way to identify it is largely from the donor. So you must send your donor media, your donor rims for culture, and you are unlikely to find success with medical management. You have to get the focus of infection out, which is often deep-seated, and therefore you need to go in for a penetrating keratoplasty. So I think what you showed is a very high threshold for surgical intervention, and the source of infection, because it is largely from the donor, look at the donor for the culture.
Also, the second eye of the same donor where it has been used, you must keep a track for that. Also, the second eye of the same donor in that patient, it is also a good idea to follow up that patient and see how he is doing.
Ma'am, it was discarded after the infection was detected in the first eye.
No, Dr. Astha's point is, in your case, that was not used till the infection occurred, but at times what happens, 2 tissues have been allotted to different patients, one patient gets operated, the other gets infection. So in that case, you have to monitor closely the other patient. We call it a met cornea, okay, the met cornea of the infected. Or you have to, like your case, you can avoid that cornea completely. Klebsiella is a very troublesome infection. It's very difficult to take Klebsiella. Also interface keratitis. So one point is, we have encountered almost 3-4 cases so far post-DALC, and our experience suggests it's better to go for a therapeutic graft immediately, because these cases, they don't respond usually, and no matter how much you do, ultimately they progress. So what's the opinion of the other panelists? So for interface keratitis, as ma'am also highlighted, the threshold for resurgery should be very low. So what's your take on that?
Definitely, the decision was very good to do immediate therapeutic penetrating keratoplasty, and again followed by another keratoplasty. So the patient has regained vision, very well managed case.
My question to the panelist, in practice, are we routinely doing the donor culture rim culture sensitivity?
Not routinely,
Yeah,
not sending the donor rim for culture.
Because usually it does not corroborate with what we're seeing clinically.
Ma'am, it depends upon some certain risk factors are present, like prolonged ventilator stay of the donor, or chronic debilitated and immunocompromised states, HIV positive status, or uncontrolled blood sugar, and this states then.
So that's a very nice point.
Donor culture rim.
I should be, I feel, but I'm not routinely sending donor rims.
So routinely people do not do that, but as he rightly pointed out, if your donor has some risk factor, or at RP center, what we do, any cornea with a death enucleation time of more than 6 hours, we routinely send for culture. And below 6 hours, there is unlikely to have some infection. So because the cost benefit ratio of that would be too high, so people usually avoid sending culture for that. But if you have facility, there is no harm. If you don't have facility, don't worry. People routinely don't send culture.
So what was your post-operative regimen? Did you start topical steroids soon after the therapeutic keratoplasty, or did you wait?
Steroids were started after the therapeutic keratoplasty to prevent the graft rejection once
So
again.
from day one?
Yeah.
So, okay, so that's a very nice point raised by Dr. Tushar. Let's have a discussion with the panelists. When would you start steroid after therapeutic penetrating keratoplasty?
Ideally, we would wait for the button culture report and then start.
For culture proven bacterial keratitis, I usually start on day one. But if it's not culture proven or if it's fungal, then I wait for 2 weeks actually.
Even that is what.
Epithelial healing is also, a criteria. Some people wait for the epithelial healing after therapeutic keratoplasty, but in bacterial, you can start. Yes, in a large graft, you can start if you know the organism.
And I also follow this softer steroids initially, and then we go on to the more potent ones.
Time has prolapsed.
So what the textbook says, because in Viva you will have to answer as per the textbook. The textbook says if it is a bacterial keratitis, after 48 hours you can start, because any recurrence post bacterial keratitis would occur by that time. If it is a fungal keratitis, there are two ways: either wait for 40 days, because fungal culture will be negative by that time, okay, if you haven't sent culture, or if your culture reports comes early and you find that there is no organism at the rim. When you are doing a therapeutic graft, don't send the culture from the center of the button for the purpose to start steroid. You have to send the peripheral part. If your periphery of the donor is clear, host is clear of fungus, then you can start steroid. Okay, so that is what is given in Smollin's textbook of cornea. So any other speaker from this session, cornea and ocular surface? Okay, I think we have Dr. Anik, right? Dr. Anik, please start your presentation. So Anik is going to speak on a very interesting topic, calotropis-induced keratitis. Anik, are you from Madhya Pradesh? You're from? Okay, good. Because I think those who are Shiv Bhakts, they often get this keratitis. So I hope Anik will highlight those points.
Do we have any other speaker for the session? What's your name? Sorry. You start here. And there's another speaker. Two other speakers. Okay.
Good morning, respected teachers and my brothers and sisters here. I would be presenting an interesting case, that is calotropis-induced keratitis. So, what is calotropis? Calotropis is a shrub and it is ubiquitous in India and especially in West Bengal, and it is known here as akondo. Now, where it is used? It is used for in indigenous medicine, quack practices, and most commonly in Shivratri Puja for Shiv ko charane ke liye. Okay? So, this produces a milky white thick sap, which profusely comes out while breaking the leaves, stalk, or plucking flowers of the plant. As such, it is not uncommon for the sap to be accidentally introduced into the eyes, and it causes marked inflammation. This report by me narrates a few such presentations and findings and their management. So, here I examine the patient. Upon listening to chief complaints and taking proper history, I examine the best corrected visual acuity via Snell chart, and then I examine via slit lamp examination the conjunctiva, cornea, and anterior chamber. And then I had to examine the corneal endothelium via specular reflection only, and intraocular pressure was measured by non-contact tonometer. And fundus was examined after dilatation and checking for pupillary defect by slit lamp with 90-degree lens and indirect ophthalmoscope. So, what do we find here? We present here 3 cases. They are all female and of 35 to 39 years of age. They had no previous complaint, but they were accidentally exposed while breaking the flowers and leaves during this coming Shivratri Puja. Then the sap went inside their eyes, and then All of them reported burning sensation and watering immediately after, followed by there was grittiness and redness, and within 2-4 hours, there was blurring of vision. But surprisingly, there was no such ocular pain per se. By best corrected visual acuity in the affected eyes was 6/60 to 4/60 in the cases. While doing the slit lamp examination, we found out there was conjunctival and circumcorneal injection, and there was presence of descended fold, that is corneal stromal edema and striate keratopathy. And the anterior chamber was quiet, and corneal endothelium and fundus was normal. This case. And now we did this thing, we gave the patient, we assured the patient, at first we assured the patient that upon taking the history that it has been caused most likely by the calotropis, and we have given him moxifloxacin dexamethasone eye drop to use 6 times per day. And on follow-up, the edema and keratopathy improved after only 2 to 3 days, and inflammation completely resolved by 7 days, as we can see in the picture, and BCVA came back to 6/6 in all of them. So based on history of exposure and clinical features, these cases are diagnosed as calotropis-induced toxic keratoconjunctivitis. The clinical course and response to treatment was very similar to a publication by Nidhi Pandey ma'am et al. That was published in Indian Journal of Ophthalmology, and none of them showed loss of endothelial cells or any intraocular inflammation. The corneal edema and striate keratopathy is probably due to the irritant nature, and the painless clinical course could be due to the analgesic property. So these are my references. I took help from these.
Thank you, Anik. Anik covered almost most of the part of toxic keratoconjunctivitis. Only one question, Anik. You stopped steroid in 1 week.
No, sir. I actually tapered the steroid.
Tapered over how many days?
So I tapered over, sir. Then the follow-up came, and I gave the moxifloxacin plus dexamethasone 4 times per day, and then I gave it BD, and then I stopped it.
So total 4 weeks, 3 weeks. How long?
3 weeks. Sir,
3 weeks. So that's the point of debate. I would like to put to the panelist. How long you will continue steroid in cases of toxic keratoconjunctivitis?
We will give at least for 2 to 3 weeks, depending on the severity. Usually I start with 6 times and then taper weekly until 4 to 6 weeks.
Yes, I follow the same. Also, I would avoid a combination of antibiotic and steroids. So, like, better to, because steroids you have to taper, and so.
But it is better to separate those and give it. But
especially here, because you generally don't have epithelial component. If you have an epithelial component, it's the traumatic.
Yes.
But the toxic component doesn't lead to epithelial, so you can stop the antibiotics sooner. And ideally, you should not taper antibiotics also. So for both purposes, that can be done. I think it's interesting that most of the case reports have females only, because females seem to be plucking the flower for the religious festivals, and very few males have actually throughout all the case series. It is
Females and pujaris, because they keep that flower near the god and they accidentally touch their eyes, and they also gets involved. So steroid, why did I ask that question, is because there is a controversy. Few people believe, although the inflammation clinically resolves, but some low-grade inflammation keeps on ongoing for almost 3 to 6 months. So few surgeons, they continue steroid for a longer duration, but as ma'am also said, few surgeons, they believe, no, once this clinical signs resolves, no need to continue steroid. Thank you, Anik. Then we have next presenter, please.
Thank you, sir.
Thank you, Anik. You presented in a jolly manner. That was nice. And you were presenting your case, and you're enjoying that presentation. That was the best part. You're Pankhudi, right? Okay. Dr. Pankhudi, okay. So this was missing. So she will be speaking on pythium keratitis. Please.
Good morning, everyone. I'm going to present a case of Pythium keratitis. Pythium insidiosum is an oomycete residing in aquatic bodies. Of all cases of keratitis worldwide, 5.9% is attributable to Pythium. It is a highly virulent and has a higher recurrence rate. It is highly prevalent in tropical and subtropical regions. It causes side-threatening keratitis, also known as parafungus, as clinical picture closely mimics fungal keratitis. The predisposing risk factors are dust, bathing in pond water, stick injury, and clay injury. Classical hallmark features shows diffuse gray-white stromal infiltrate with reticular dot infiltrates, tentacle-like extensions, peripheral guttering, along with thinning with furrowing, and rapid limbal spread is seen in these type of cases. A 52-year-old female presented to the OPD with history of entry of dust particle in left eye 10 days ago, complaining of gradual, progressive, and painful diminution of vision. It was associated with redness, watering, and photophobia. Her visual acuity in left eye was PL positive and PR accurate. In right eye, it was 6/24, improving to 6/12. In left eye, periocular lid edema along with circumcorneal congestion was present. Grayish-white corneal infiltrate of 8 into 7 millimeter size was seen approaching limbus inferotemporally. Epithelial defect of 8 into 7 millimeter was present. Feathery margin could be appreciated and several dot-shaped infiltrates was seen. Gram staining, it shows thick cell wall, a few septate and a ribbon-like folding patterns of hyphae and chlamydospores. On KOH mount, it shows long, sparsely aseptate hyaline hyphae. The final diagnosis of left eye Pythium keratitis was made, and topical linezolid azithromycin netamycin was started 1 hourly. Along with it, oral azithromycin was started. On follow-up, it was seen that the corneal infiltrate size and epithelial defect size has decreased. Along with it, vision improved to hand movement close to face. Stromal lysis was seen. On further presentation, radiating DM folds was appreciated, suggestive of impending perforation. So left eye tissue adhesive plus bandage contact lens was planned under topical anesthesia. At 3.5 months of presentation, the vision improved to counting finger at 2 meter. Along with it, leukomatous opacity from 1 o'clock to 6 o'clock could be seen, and superficial vascularization could be appreciated with cataractus lens. Pythium keratitis on routine smearing present as a perpendicular or obtuse septate or aseptate branching hyphae. The gold standard for diagnosis is culture or nutritional agar, preferably blurred. Cream-colored colonies with zoospore formation is confirmed using the leaf incarnation method. As it lacks ergosterol, therefore, antibacterial are more effective than antifungal. In any cases of Pythium keratitis, we should start with antifungals. When the culture is positive, then linezolid is started. If the ulcer size is more than 4x4, then oral azithromycin it should be added. The take-home message is corneal scraping should be done for all the ulcer patient. There is a high index of suspicion, especially in non-responding cases, and close follow-up and prophylactic measures should be taken. Thank you.
Thank you, Pankhuti. We'll take up the next case, then we'll discuss this case. Yeah, please. Next presenter. So in the meantime, when to suspect Pythium? Pankhuti, if you are there, you can answer this on the mic.
If infiltrates are present, along with it, peripheral guttering are seen, rapid limbal spread. If we follow it closely, then we'll see rapid limbal spread.
Any indication for symptoms?
So it will be very painful, and tentacles-like extensions will be seen, peripheral
Pictures
guttering.
will be like fungal keratitis, but the classic like signs are more than symptoms. That is not there in Pythium.
Thank you, sir.
Next presenter कहाँ है? Yeah, Dr. Kopal, please start your
Good
presentation.
morning, everyone. I'm going to present on carbide-related ocular thermochemical burn. Ocular burns account for 7.7 to 18% of ocular trauma, which can lead to chronic sequelae of chemical injury, that is dry eye, persistent epithelial defects, limbal stem cell deficiency, symblepharon formation, and entropion. Calcium carbide, which is used for multiple purposes in India, that is agriculture-related, industrial works, as well as firecrackers also. In acute phase, we should immediately irrigate the injury as well as removal of possible particles is necessary. while the high-grade ocular injury required surgical intervention such as amniotic membrane transplantation with tarso. So earlier epithelialization of ocular surface is required. So our case of 16-year-old male from Bhojpur, Bihar presented to our OPD with complaints of diminution of vision, redness, watering in right eye. He had a history of firecracker injury in right eye, which was followed by diminution of vision. His uncorrected visual acuity in right eye was 636 part. On ocular examination, lid and adnexia finding shows burn marks or lid with singeing of flashes and mucoid discharges. In conjunctiva, it shows congestion with carbide particle in superonasal quadrant of conjunctiva with superior conjunctival and limbal epithelial cells involvement. In corneal examination, it shows epithelial defect of cornea involving limbus in 6 to 9 clock hours as well as bulbar conjunctival involvement. So, in corneal examination, it also shows stromal and endothelial scarring. There was dispersed carbide particles in epithelial and anterior stromal layers. Thus, on the basis of ocular examination, final diagnosis of right eye grade 4 Dua's ocular chemical injury was made. The patient was immediately taken for irrigation with double lid eversion technique and was managed medically with topical steroid, antibiotics, cycloplegics, and anti-glaucoma medication, and was planned for right eye amniotic membrane transplantation. On follow-ups, at first week, the vision was 636 with purse ring sutures of amniotic membrane transplantation with BCL was there. At third week, vision of 624 was there with disintegration of AMG was there. At 1 month, vision was improved to 624 with corneal clarity increases. So calcium carbide is an alkali-related ocular injury. As it was alkali, it shows deeper penetration inside the cornea, which lead to ciliary body damage, as well as decrease in level of glucose and ascorbate in anterior chamber, which can further lead to collagen synthesis hampering and elevation of IOP. In surgical management, we should first rule out whether it is an acute phase or late phase. In acute phase, amniotic membrane transplantation as well as tenon's advancement is done. In late reparative phase, limbal stem cell transplantation with amniotic membrane transplantation is done. And in late rehabilitative phase, ocular surface reconstruction, limbal stem cell transplantation, PK and keratoprosthesis is preferred. So, in conclusion, calcium carbide is an alkali, most commonly affect young age people. Early appropriate medical and surgical intervention required for proper management, and multiple surgical interventions are required. Early treatment reduces long-term sequelae of chemical injury. Thank you.
Just ask you, do you know why this carbide gun injuries, like what was the child, was he a child? He was a child, na? Your patient?
Yes.
So exactly what was he doing when he got injured?
Ma'am, he was making firecrackers.
Yeah, exactly. So those YouTube videos which are showing how to easily assemble it and make it, that message has to go, that has to be discouraged. Because these are young people, what they do is that they take the metal pipe, they put that carbide gun and a balloon and a lighter, isn't it? That's the video.
Yes.
So they think it's very simple, and what they do is when it's not bursting, they peep through those pipes and suddenly it bursts on your face. So the social message is this, that those YouTube videos should actually be discouraged.
Actually, once they've banned firecrackers, carbide doesn't form part of the chemicals that have been banned. So
Yes.
carbide firecrackers are actually increasing popularity because of the ban of the other firecrackers. So, and in fact, mostly what you said is they're looking into it. That's why carbide injuries are usually right side, because right-handed people hold it in the right side and they actually peep into it with their eye.
Yes.
And then it blasts into the eye. So both the messages are very important, that of course the government should also recognize the risk of carbide, and we should give the social conditioning as well.
True.
With this, I think we have completed all the case presentation. Anyone left? You are left? Okay, please come on.
So in cases of thermal injury or chemical injury, so with grade 4 and above, if you're doing the amniotic membrane transplantation for epithelialization, it's very important to explore and document how much is the area of scleral ischemia, and if any amount of scleral ischemia is present, you should also combine it with a tenon advancement or tenonplasty to restore that blood supply. Otherwise, most these severe burns, thermal burns, which are more severe than chemical and grade 4 and above, the globes progress to phthisis. So that should be done along with your AMT.
Give her PPT. You're Shivangi, right?
Sheel Meshram. It was there in the previous one, which was open. No, Sheel Meshram, this one. Good morning, everyone. I will be presenting lid margin mucous membrane grafting in lid viper keratopathy. There is no conflict of interest and no financial disclosure. What is a normal lid viper? It is that part of the lid which is in contact with the globe. It extends from the mucocutaneous junction to the sulcus subtarsales and from the medial punctum to the lateral canthus. Lid margin keratinization is posterior migration of the mucocutaneous junction. This is a case of a 9-year-old male child who came with chief complaints of watering, redness, and difficulty in opening eyes in ambient light for 3 months. There was history of fever with rashes, redness in both eyes, lip swelling, oral erosions, and was diagnosed as Stevens-Johnson syndrome secondary to mycoplasma infection 3 months back. The uncorrected visual acuity in right eye was 6/60 and in left eye was 6/12. The ocular examination of the right eye revealed lid margin keratinization, posterior migration of the mucocutaneous junction, atrophic meibomian glands with plugged meibomian gland orifices. Corneal vascularization was seen with corneal haze and few superficial punctate keratopathy. Ocular examination of the left eye also revealed similar findings. The clinical clues suggestive of Stevens-Johnson syndrome scored 8 out of 10. The investigations were done, and the patient was mycoplasma IgG positive. The final diagnosis of both eye lid margin keratinization with lid viper keratopathy as a sequel of Stevens-Johnson syndrome secondary to mycoplasma infection was made. The patient was planned for mucous membrane grafting. The preoperative consideration were the posterior migration of the mucocutaneous junction and the lid margin keratinization and some wetness of the eye. The donor area is usually the upper and lower labial mucosa with no ulceration and fibrotic changes, and prophylactic antiseptic mouthwashes are started. The preoperative counseling is done, and the procedure is generally done under general anesthesia, and throat is packed and cuff tube was used. Mucous membrane grafting was done. The donor site is the lower lip labial mucosa and the recipient site where the mucous membrane was grafted. Post-op day 7, we can see the anterior graft margin which was sutured with 60 polygalactin interlocking sutures, and the posterior graft margin was fixed with fibrin glue and BCL was applied. Graft was in situ and well opposed. According to Shanbag et al., 2/3 of the patient present more than a year after acute SJSR10, 99 without prior amniotic membrane transplantation and low vision in 60% of eyes. Lid margin keratinization causes lid-related keratopathy. If timely treated with mucous membrane grafting, it can halt the natural course of the disease and improve vision in affected eyes. The follow-up of right eye at 1 month showed a new mucocutaneous junction, the corneal vascularization which has decreased, and the SPKs which has reduced. The follow-up of left eye at 2 months revealed new mucocutaneous junction, the result corneal vascularization, fewer SPKs, and the rest of the cornea was clear. The lid viper keratopathy is a common chronic sequel of Stevens-Johnson syndrome and toxic epidermal necrolysis. Posterior migration of the mucocutaneous junction and lid margin keratinization leads to corneal epitheliopathy. Mucous membrane grafting helps form a normal mucocutaneous junction. If timely operated, it can lead to reversal of corneal vascularization and prevent corneal blindness. Thank you.
Thank you. How do you pronounce your name?
Sheel.
Sheel. Thank you, Sheel. And I think Dr. Jaya is quite into this ocular surface. Ma'am, what's your comment on this?
Now practically my ocular surface work has reduced But yes, lid viper keratopathy, that's and mucous membrane graft really works for it.
In fact, people are doing it prophylactically nowadays, lid margin MMG. So even if you don't know the extensive MMG or ocular surface procedure, at least it's a good technique to learn. If you at least know this, so you can do the initial part, and that will save patients' eye. And future surgeries become quite easier. So with this, I think we have come to a conclusion of this cornea and ocular surface session. And our next session will be on ocular immunology, where we have a mixture of both some cornea and retina cases. So few of our panelists, they are going to continue stay here, and I would like to request Professor Sarita Berry ma'am and Dr. Anurag to come onto the dais. And I hope the presentation you all have uploaded your PPTs.
So while that gets done, I'd just like to talk about mycoplasma-associated conjunctivitis itself is a cause for cicatrizing conjunctivitis. So you often see these young patients with acute conjunctivitis and symlifera developing, and you do an IgG and it's actually mycoplasma conjunctivitis. And oral azithromycin actually works quite well in these patients. So it's a it's a new entity now. There are publications on it, and I think that itself is quite important as well.
Ocular immunology session, speakers, if anyone is there. Yeah, okay, you have uploaded PPTs, right? So, okay, Singe. So, Prince, can you come little bit forward and take a picture of us? Speaker ka picture to panelist.